just do the treatment straightforward. You need bone grafting, you need implant placement.
Okay, yes.
And I don't think that even with these sort of functional problems that we've seen yesterday, I don't see that these functional problems affect too much your mouth. So I would do at least implant placement, at least temporaries, and maybe I will perform analysis again, because I'm not sure that doing everything that we could do for the patient is for good. You have good teeth, they are quite healthy, or at least the teeth that are left here. You have problem with the bone, with some teeth displacement, but I don't think that is something very problematic. But let's see the occlusion. Let's see the most interesting part, yes? So,
παρακολουθώ και τώρα, να σου πω την αλήθεια, αυτό ήθελα να τον ρωτήσω όσον αφορά τώρα το θέμα της άρθρωσης της σύγκλησης. Please continue. My question was about the occlusal plane, but I see that you are going to explain it.
Well, actually, one more thing we can see here. Let's go back here. So, remember I told you X-ray mode, yes? So we can go, I like it very much, to X-ray mode, and there is advanced cephalometric here, and there is advanced. When you go to advanced, you see X, Y, Z slice. You go to the X slice, and what you can do is you can just go with the slice to any condyle you want, and you can see through condyle not only the one point of the condyle as we see in X-ray, we can see lateral pole, medial pole, the whole condyle head. Let's see what happens with Panayotis. Look, I think maybe he doesn't have a disc on the right side. I don't know, because without MRI I couldn't confirm it. But I can say that from the point of view of the structure, the way the condyle looks, actually we've seen it also in a CBCT, and from the point of view of the space we see here, let's do it like this. From the point of view of space we see here, Panayotis is quite okay. Okay, let's have a look at another one, the one that I didn't like. The one that I didn't like. Yeah, I didn't see it before, but you see, this joint I didn't like. And you see what happens here?
No, what's wrong?
Look, it's called beaking. So it means that there was a time of Panayotis' life when his disc went out and didn't return, and maybe Panayotis didn't notice that, and there was like a friction of the bone structures on each other. So we see that a little bit flattening of the condyle, see, and also we see here space is less. So something is not so good with this condyle. What does it mean? It doesn't mean that we have to say, oh, you have TMD, you have to be treated by the splint and so on. No, I don't think that, because I actually one of the dentists who believe that joint treats itself much better than doctors do. But I have to warn the patient, you know what? We will not be in a hurry with you. We'll do this, we'll test it on temporaries, and we have to be sure that your system is still in adaptation. Because until we will not just increase the threshold of adaptation capabilities of the patient, we are good. But sometimes without treatment, patient feels good, patient feels fine. His joints are killed, his condyle are small, his disc is not anymore, and he feels good, no complaints. But then we can do something that we think is good for the patient. We didn't take it into consideration, and finally the patient has pain, he has discomfort, he can chew properly. What happened? Are we to be blamed? No. It's just that we took the patient from his adaptation mode to the disadaptation mode. So he was in compensation, but something that we did decompensated the patient. And it's very, very good to know it in the beginning. That we say, okay, Panayotis, your joints are fine, they're not the best. Actually, it's very hard to find the best joints, especially when it's missing. But we have to be careful with you. It means let's spend with temporaries a little bit more time than we usually do. Let's have them, well, not maybe for 4 months on the implants, but let's have them maybe for 6, 7 months. And let's see how you will feel. Let's do another analysis later, and let's confirm that we can go on. It's not that, wow, I will not treat you, look at your joint. No, it's just we have to be careful. That's it. Because the joint, as I tell my patients, this joint was living without any doctors, any gnathologists for 10,000 years at least, if we believe not in Greek mythology but in evolution. Yes. So, and I tell my patients, I don't know any cemetery stone where it was written, this patient died or this person died because he couldn't close his mouth or he couldn't open his mouth. The joint will adapt. TMJ will always adapt to the life of the patient because we have to chew. That's the life-saving joint. So we can have mess with the knee joints, with elbow joints, but TMJ will always work. What we have to work on is the quality of life. It means that this joint has to work without pain and without discomfort. I don't frighten patients that, you wouldn't be able to chew or you wouldn't be able to open or close your mouth. I tell my patients, no. If the problem arises, finally you will be able to go back to that. Only thing that I could do for you is trying to decrease the probability that these things would happen in your life too often. Something would happen, because occlusion is only one part of the equation for the TMJ. Stress, genetics, connective tissue diseases, and so on could also affect TMJ. So that's why I think that we have to be aware that this right joint may be experienced in its life, and this is more lateral pole. So experienced in life some changes that happened with this joint. Actually, I can see that my point, I placed it in the correct position, but it's not that important right now. And we have to be aware of that. So I don't think Panayotis needs a splint. But maybe I'm wrong, and we'll see that. I think Panayotis needs implant. Well, there are doctors who charge 20,000 euros for diagnostics that will say it's scary and you have to do something about it. But I think, there was scientific research that, myogymnastics and cognitive behavior training, not to just close the mouth and parafunction without functional need, is the same efficacy of the treatment as splint therapy and total rehabilitation. So sometimes what I do with my patients, the patient comes and I see that the patient has parafunction, like daytime bruxism. It's more dangerous than nighttime bruxism. Because when the patient talks with me, I follow the patient and what they're doing. And actually, if you want, I can show you in Russian how I do that, these videos.